In this episode of the ASC Podcast with John Goehle, we discuss the latest news and trends in the ASC industry and review the proposed 2026 CMS Payment Rule for ASCs and HOPDs.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs, and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 251 of the ASC Podcast with John Goehle, recorded on July 21st, 2025, from our studios in Spencerport, New York. I'm Sue Kronka, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by their relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry, and he is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So, Sue, it is about 11:30. We are trying to get this episode out before our drop-in session. We have a drop-in session today on Monday. So for those of you that are patron members, you know that during the summertime we experiment a little bit with different days of the week. So today it's going to be Monday. And the other reason that I'm exhausted is because we have that puppy who is keeping us very busy right now.
He's keeping you especially busy. I'm kind of, because you'll be heading out of town this week and the weekend, and then coming up in the next couple of months, be very busy. So I'm kind of leaving it on you right now, unfortunately for John. I know you're not getting much of a break, but
she's an absolute joy, but she has got a lot of puppy energy. So good luck in the next couple days here as I'm out of town for a bit. And to that end, the AAHC retraining for all of our surveyors occurs at the end of this week, so from Friday through Sunday, and we are very excited. We have 4 surveyors on our team at Ambulatory Healthcare Strategies, and we get together a lot, but we don't get together with all of our colleagues. Yep. And so we're looking forward to it. We do have very interesting conversations. We learn a lot from AAHC, and we talk strategy, try to determine what can we do to improve the quality of the service that we provide to all of the AAHC accredited organizations. So more news on that. If there's anything that's of interest to a general audience, I'll make sure I bring that back for our next episode.
Yeah. And we just wanted to mention that August, next month, is National ASC Month. So
That's right.
If you want to plan ahead and do something nice for your staff, or try to bring people in, politicians, people from the news, just kind of spreading the word about ASCs, that's a great time to do it.
And it really is. There's a lot of information, especially if you're ASCA members. They give you a packet of information that you can provide to local news crews, or if you're trying to get politicians in. I know it. If you're like me, I never really enjoyed that so much, bringing politicians into our surgery center, but it is very valuable for them to understand what it takes to run a surgery center. So even if you're apolitical, it's a great opportunity to show your place off to the community. So definitely something to look into. And your state association, some of the state associations also try to couple the national ASC month with state recognition. I know that's the case in New York. Sue, we do have some news.
In Ambulatory Surgery Center news, they had 9 quotes that capture 2025 for ASCs. Now, I only pulled a couple of them out, but I really want to recommend anybody who's not subscribing to ASC News. It's a really great source of information. And I pretty much am reading these 2 word for word because they really summarized it very well. So I just wanted to give credit to them. So one of the quotes is, facilities management has been a learning opportunity. Understanding ASC requirements in advance is vital because they significantly impact project timelines and finances. And that was from Crystal Agner, Administrator of Surgical Suites of Coastal Virginia and Port Warwick Surgery Center. So before I do the summary, I know it's just, I grabbed this because it's something we run into all the time.
Yeah, I can't emphasize this enough that even if you have done fantastic on previous surveys from a life safety standpoint, there's a lot of changes that in the way surveyors are looking at your surgery center. But to the point here is that when you're designing a surgery center, it is extremely important to bring people in that really know not only the state and local regulations, but more particularly the CMS regulations with regard to construction. And this can be very, very expensive. Again, Sue, we had another mock survey this week where our team was brought in to do a mock survey of a surgery center that is waiting or wants to go through CMS certification. And our mock survey team basically said, there is no way they will pass. Yeah. And it all falls to the architect and the engineers who designed it without taking into consideration the CMS regulations. So
ASCs particularly, yeah.
Yeah, I'm really hoping to save those of you that are developing surgery centers a lot of money. Bring experts into this process early. If you haven't hired a firm that has specific experience in ambulatory surgery center, in other words, surgery centers that are built under the ASC, under the CMS conditions for coverage and interpretive guidelines, as well as the applicable life safety code, you really need to look into that quickly and perhaps bring people in, like we have on our team, our life safety team, to do a mock survey very early in the process so that you can make the changes necessary before you actually have a survey. At that point, once you're up and running, once you're built and waiting your Medicare certification, it's going to be a very expensive process to make those changes, and of course cause further delays. And to your point, Sue, too, is that there's a lot of delays that occur. I don't think I've ever seen a project ever go off according to the timeline that everybody set in the very beginning.
I know, and you always say that to people, and they're like, no. Our architect said it's right on target.
On target, and the construction manager's doing a great job, yeah.
And they probably are, but something will happen.
Well, and of course, it's not always within the control of the construction manager and the architect. No. You have all these approvals that have to come from governmental agencies.
So, and swinging back to the article, their thoughts on the quote is that captures one of the biggest blind spots in HOPD to ASC conversions, which is a trend that has picked up steam in 2025. Hospital systems often assume they already know what it takes to run a surgery center, but the facility requirements are completely different. Things like firewall separation, emergency protocols, and generator testing can derail a timeline if they're not accounted for early. As more systems look to convert space in response to reimbursement pressure and payer site of service shifts, this kind of operational due diligence is becoming essential. And the second quote that I pulled out is by AmSurg CEO Jeff Snodgrass. By joining one of the nation's most respected health systems, we are strengthening our ability to serve patients and communities while continuing to elevate the outpatient surgical experience across the country. And they're saying this highlights one of the defining ASC trends of 2025, the strengthening of ties between ASCs and large health systems. With Ascension acquiring AmSurg, one of the largest ASC operators in the U.S., this year's biggest story is about consolidation and integration. And I know we've, discussed articles talking about that, how there's so much teamwork and these large healthcare companies are really trying to get into the ASC market.
Well, and they're trying to partner with health systems, which is what Snodgrass is talking about here. And I think that this is a trend that I've seen over the years. It kind of waxes and wanes. And right now, I think it is definitely on the uptick as hospital systems, as healthcare systems recognize the need to be able to move some of those cases off campus into less expensive areas to be able to efficiently provide those services. So I think we'll see this continue. And of course, partnering with large organizations like AmSurg, a health system can really, expedite the process and make things happen a lot faster.
And we're going to provide that link as well as this next one from Healthcare Dive. It's an article from June 23rd summarizing how health insurers are pledging to reform prior authorization, which is good news because that's been a huge problem recently.
Especially for surgery centers.
Yes, yeah. A coalition of 48 influential for-profit and nonprofit insurers are promising to make some reforms. These health insurers have agreed to 6 new commitments to ease the administrative burden for healthcare providers and to allow easier access to care for patients. So those 6 are eliminating some prior authorization requirements, honoring existing proposals from a member's previous plan during a 90-day transition period when the member is changing to a different coverage, if that makes sense. So, if you've just gotten something approved, you'll have that 90-day transition period. They will be giving explanations on prior authorization decisions and will provide guidance on how to appeal denials. Because I think sometimes you don't even know. Sometimes it's almost done by AI and they just, it's denied and you got to keep on fighting it. So
right,
that'll
and it
make it easier.
Right, and there's a lot more back and forth that needs to be done, which really delays the care. And again, this all comes down to, it's important for ASCs to get paid, obviously, and to make sure they're going to get paid. Yeah. But it's the patient that's caught in the middle on all of these things.
Yeah. Especially when it's a timely procedure, time-sensitive procedure where your health could deteriorate pretty quickly. By 2027, the payers said they would standardize data and submission requirements for electronic prior authorizations, and at least 80% of electronic prior authorization approvals will be answered in real time by 2027. And payers also promised that all prior authorization denials will be reviewed by medical professionals. CMS Administrator Dr. Oz noted the pledge is not a mandate, it's not a bill or a rule, this is not legislated. It's an opportunity for industry to show itself. And he said that the government would be tracking compliance closely and they are open to regulation if insurers fail to meet the new standards.
I am so impressed with this. This really is, I think we've always felt like insurers are trying to find roadblocks to improving the efficiency and scheduling cases. And this is nice to see this. I think, of course, the reason it's happening is because there's a threat looming over them of possible regulatory intervention. But actually setting a standard like 80% of electronic prior authorization approvals will be answered in real time by that year, which no doubt is going to be, AI based, I'm assuming, based on the way that it was worded there. I think that gives a number that the government can check. And, use that to determine, okay, if you're going to continue along this route, if these are the changes you're going to make, then we'll stay out of it. But of course, if you don't meet those goals, then perhaps it's time for us to intervene. So definitely and this is one of the complaints that we have heard over and over again. We don't talk about it a lot on the podcast, but it is definitely one of those things that we're hearing from the financial departments and surgery centers is how difficult it is to get these approvals of these authorizations done on a timely basis.
They don't have as large of a staff as some of the bigger health systems, so it can really be hugely time-consuming getting something done that your doctor knows has to be done, that is good for the patient, but they're spending all this time kind of fighting with the insurance companies. So
and sometimes it's outside of their control because it's the physician who's scheduling the case and is responsible for that approval. So again, let's think positively here, and hopefully things will be changing in that front. Let's take a short break, and we're going to talk about the 2026 Payment Rule, which just came out in early July, and we'll give you some highlights. A little teaser here. It's really good news this time around. So let's take a short break, and we'll be right back. It's been a long day, and the surveyor's just left, and you are exhausted. And looking at the list of items that you have to address, you wonder, how can I deal with this and still take care of my patients? More importantly, you wonder, how can I ever keep up with all of the regulations, standards, and accreditation requirements? How can I always be prepared for a survey and reduce my stress levels? Well, that's what Ambulatory Healthcare Strategies does, day in, day out. We become your outsourced regulatory and accreditation resource. We can maintain your policy manual, develop your education programs, help out with fire and disaster drills, do your risk assessments, oversee your quality improvement activities, help run your quality improvement meetings and governing body meetings, and we can even prepare your monthly or quarterly financial statements and help you figure out where you are financially. We are a retainer-based service. We don't take ownership. We don't charge based on your revenue. We have one fixed monthly fee, and we can tailor your services to your exact needs. So whether you're looking for help getting over a survey, preparing for a survey, or looking for a long-term relationship to assist you with your ongoing regulatory and/or financial needs, please give us a call at 585-594-1167 or email us at info@ahstrategies.com. That is info@ah-strategies.com, or visit our website at ah-strategies.com. We're back for the focus segment, and today we're diving into the 2026 proposed CMS Payment Rule for Ambulatory Surgical Centers and Hospital Outpatient Departments, which was released in early July 2025. This is a proposed rule, we need to remind you. The final version is expected in early November after public comments, which are due by September 15th, 2025. Sue, this is a critical topic for our ASC listeners, so let's start with the core issue, how Medicare determines ASC payments and why it's so important.
That's a really good point, John. Some of our listeners are new to the ASC world, and honestly, even experienced ASC leaders don't always recall the details of the payment system. So let's break it down to the basics. How does CMS decide what ASCs are paid?
Yeah, that's a good question. And as we said, this is complicated, but I'm going to try to make it as simple as possible. So picture this, Sue. Medicare oversees more than 6,000 ASCs, as we know, nationwide, performing all kinds of outpatient surgeries, cataracts, colonoscopies, knee arthroscopies, etc. The payment system is built on the Hospital Outpatient Prospective Payment System, better known as OPPS. And what CMS does is it groups similar procedures into ambulatory payment classifications called APCs. Each APC has a relative weight based on the resources that are required. For example, the staff salaries, equipment, supplies, and these rates come from hospital cost data. It's important to note, hospital cost data, not ASC cost data, unfortunately. And primarily this comes from the 2024 claims. CMS multiplies the weight by a conversion factor to calculate the payment rate. For 2026, they're proposing a 2.4% increase in that conversion factor from a conversion factor of $54.895 in 2025 to roughly $56.207. And again, that's the proposed rate at this point. It does usually change between the proposal and the final rate.
Mm-hmm. Okay, so why are the ASC payments lower than the hospitals for the same procedures?
Yeah, that's a great question, and I think many ASCs ask that same question all the time, Sue. ASCs operate with greater efficiency, generally. No emergency departments, no overnight care, just focused on outpatient surgery. And CMS recognizes this lower overhead and sets ASC payment rates at about between 50 and 70% of the hospital outpatient rates. They rely on hospital cost reports, which ASCs don't submit. And we've talked about that a number of times on the podcast about how ASCs are one of the few healthcare organizations that rely on Medicare payment that don't actually have to submit cost reports. So that's an important thing to remember. And that's one of the reasons that these rates sometimes are kind of unusual or vary so dramatically. The 2.4% update is based upon the Hospital Market Basket Index, which tracks healthcare costs like salaries, medical supplies, and utilities, which are projected to rise 3.2%, minus a 0.8% productivity adjustment to encourage efficiency. But here's the key. Not every procedure gets that 2.4% increase. CMS recalculates the APC rates annually based upon the new data, which comes from the cost reports. So some procedures may see higher payments. Others are going to see lower payments, though the overall system average is about 2.4% for the ASCs meeting the quality reporting requirements.
Okay, so what happens if an ASC doesn't meet those quality reporting requirements?
Well, failing to comply with the ASC Quality Reporting Program, we call it ASC-QR, results in a 2% reduction on the update, leaving just 0.4% increase. In other words, 2.4% minus 2% comes down to the 0.4% increase. That has a significant impact when margins are already tight. The ASC Quality Reporting Program requires submitting data on quality measures like infection rates or patient satisfaction, which CMS shares on Care Compare to help patients choose facilities to go to. It's about transparency, not hitting specific benchmarks, but not all ASCs actually have to report, and we'll cover those exemptions later.
Okay, so let's talk about that 2.4% update. I know not all of the procedures increased by 2.4%. Can you delve a little bit more into that?
That's correct, Sue. The 2.4% is a baseline, but specialties experience it differently because CMS adjusts the APC rates based on updated cost data from the hospitals, which we just mentioned. To give you a sense of the variation, let's look at ophthalmology, a high-volume specialty for many ASCs. Before I do, I have to mention that the CPT codes are copyrighted by the American Medical Association and all rights are reserved. So for cataract surgery, which is CPT 66984, that's the major one, the 2025 rate is $1,214, but the proposed 2026 rate drops to $1,157, a 4.7% decrease. Trabeculectomy, which is 66170, follows a similar pattern, falling from $1,214 to $1,157, down 4.7% also. But YAG laser capsulotomy, CPT 66821, edges up from $295 to $297, a 0.1% increase. And that's still shocking to me, given that YAG lasers are often done in the physician's office or the surgeon's office. Vitrectomies, 67036, rises from $2,094 to $2,231, which is a 6.5% increase. And blepharoplasty, 15823, sees an actual significant increase from $982 to $1,136, which is up 15.6%. These swings show how APC recalibrations can differ widely from the 2.4% average. I'll go into some of the other specialties now. For gastroenterology procedures, the major colonoscopy codes 45380 to 45386 went from $633 to $658, which is an increase of about 3.98%, while the major EGD codes 43235 and 43236 actually went down from $503 to $501, a decrease of about 0.52%. Another example is pain management. Pain management epidural injections went from $372 to $387, an increase of about 4.03%. And again, Sue, that's kind of unusual. Again, those are procedures that are often done in physicians' offices, and we're seeing an increase in that rate. And for a final example, for many of our surgery centers that do orthopedics, knee arthroscopy 29881 went from $1,579 to $1,647, which is an increase of 4.3%. We should note that the numbers we're quoting here are the national unadjusted rates. The national rates are adjusted based upon wage adjustment factors for each of your communities. For example, high-cost urban areas will have higher wage adjustment factors than rural areas due to the differences in wages. We don't have time to go through all of the codes, obviously, but we will provide links to the proposed rule, which include links to the spreadsheets that we use to calculate the new rates.
So there's some really significant variations in the rates from that 2.4% base increase.
Yes, and that's why listeners shouldn't get too excited about the 2.4% rate or disappointed, depending upon which way they go, because I think we all agree that 2.4% is just not enough. But they do need to look at the individual procedures and how the procedures that they do in their facility are affected. I did want to note the American College of Cardiology noted that adding complex procedures like the new cardiac ablations to ASCs could shift volumes, but payments depend on CMS finalizing those APCs. So one procedure may increase while another may decrease, just like the other rates. But the overall universe of ASC procedures should average out to that 2.4%.
So that's a huge challenge for ASCs as they're planning their budgets, especially with ophthalmology with all their ups and downs. So what's the Ambulatory Surgery Center Association or ASCA saying about this proposed rule, and how are they involved now?
So as our listeners know, we always support ASCA, and I have a long-term commitment to working with ASCA on this. So they're very much engaged in this, Sue, serving as the industry's advocate. They're rallying ASCs to provide feedback during the comment period. In their July 2025 statement, ASCA's CEO, Bill Prentice, who's been on the podcast a number of times, by the way, he said, while we welcome the proposed 2.4% update, it falls short of addressing the escalating costs of staffing and supplies impacting ASCs. And we're urging CMS to reconsider the productivity adjustment and align rates with the true cost of delivering high-quality care. ASCA is preparing a comprehensive response, analyzing the payments, the procedure additions, and quality measures to advocate for sustainable policies. And if you are a member of ASCA, you can actually get a full payment update, a spreadsheet that shows the payment rates. I'm not sure if it's out yet as we publish this episode, but they will have it out shortly. And that's a quick way, rather than using the spreadsheets that I'm going to give you a link to. If you're an ASCA member, you can download that pretty easily from their website. ASCA is also hosting some webinars. Unfortunately, I was doing a survey while they did the webinar this last week, but I know a recording will be available. And they're also providing model comment letters and offering workshops to help members submit impactful feedback by September 15th. By aggregating all of these comments from ASCs, ASCA strengthens the industry's voice, ensuring that CMS hears a unified perspective rather than scattered individual responses, which carry more weight in shaping the final rule. I don't want to discourage people from doing by sending their own letters out there, but definitely working with ASCA will give more power to our comments.
And this is why we always advocate for our listeners to consider joining ASCA. Absolutely.
ASCA is indispensable, Sue. They're advocating tirelessly with Congress and CMS to protect ASCs from unfavorable policies and to promote fair regulations. They provide practical tools, current comment templates, cost data guides, regulatory updates that simplify compliance and advocacy. Their conferences, webinars, and newsletters help ASCs keep informed on complex rules like this one. As Bill stated, ASCA members are the backbone of change, amplifying our voice to ensure patients access affordable, high-quality care. Joining ASCA means that you're not just managing your center, but helping shape the future of outpatient surgery. So I encourage every listener to visit ASCassociation.org and become a member. It's a critical investment in your ASC and the industry.
I agree. Now, what else is CMS proposing that's generating discussion among ASCs?
So the major focus is the ASC Covered Procedures List, or CPL. CMS is proposing adding an additional 547 procedures, which is fantastic compared to some of the prior years. 276 new codes and 271 from the inpatient-only list, which such as certain cardiac ablations, which, again, is a major focus in the last couple of years. This aligns with their 3-year plan to phase out the inpatient-only list, allowing physicians to choose ASCs over hospitals for more complex cases and to bring the cost of care down for the Medicare system. The American College of Cardiology highlighted that this could reduce patient costs by shifting procedures to ASCs from the hospital environment, but it requires centers to strengthen safety protocols. And this is really a significant opportunity with added responsibilities.
It is exciting, but it could also be a big challenge for some ASCs. So are there other payment changes we should highlight?
Yeah, CMS has emphasized a non-opioid pain management. And we talked about this on the podcast, many times. But they're going to be extending separate payments for 5 drugs and 6 devices through December 31st, 2027. This is significant for ASCs that are performing, in particular, orthopedic and pain management procedures such as nerve blocks. It supports safer patient outcomes by reducing the reliance on opioids and reflects CMS's response to longstanding industry advocacy, including from ASCA, for better pain management options. Now let's turn to the ASC Quality Reporting Program, or ASC-QR, as it's a key issue for many of our listeners, and we talk about it a lot on the podcast. CMS is proposing some significant changes this year, unlike previous years, which we've mentioned, particularly around measure removal. Sue, what's the overview?
The ASCQR is undergoing a major overhaul, John. First, it's important to clarify that some ASCs are exempt from reporting. Centers with low Medicare volume, or fewer than 240 claims per year, or those not performing surgical procedures, like certain endoscopy-only facilities, they can skip the ASCQR requirements. CMS allows these exemptions to avoid burdening small or specialized centers, such as rural ophthalmology ASCs, with mostly private pay patients. ASCs must apply annually, and CMS reviews claims data to confirm eligibility. For most ASCs, though, reporting is mandatory to avoid that 2% payment reduction. CMS is proposing to remove 4 measures to reduce the burden, and they are the COVID-19 vaccination coverage among healthcare personnel measure, which is effective for calendar year 2024 reporting, which would impact calendar year 2026 payments. And starting with calendar year 2025, reporting for calendar year 2027 payments, the facility commitment to health equity, screening for social drivers of health, and screen positive rates for social drivers of health. They're also introducing a new patient-reported outcome-based performance measure, the Information Transfer Pro-PM, which is focusing on how well patients understand discharge instructions like pain management or recognizing complications. It's voluntary starting in calendar year 2027, but mandatory by calendar year 2029, and will affect payments in 2031.
So that is a significant change. First of all, it is great that we are getting rid of the COVID vaccine coverage requirement, which was very difficult for many centers to comply with NHSN. But for a second, let's dive into those exemptions. Why do some ASCs get a pass on the ASC quality reporting program?
Well, CMS recognizes that small ASCs or specialty centers like those with under 240 Medicare claims annually or the non-surgical facilities don't have the volume or the infrastructure to handle reporting. Imagine a small ophthalmology ASC in a rural area or an endoscopy center doing diagnostic procedures, not surgeries. Requiring them to report would add costs without really providing useful data. CMS evaluates claims history, and eligible ASCs can apply for an exemption each year. This helps smaller centers focus on patient care rather than compliance paperwork. But most ASCs will still need to report to maintain their full payment update.
That's a fair approach for these smaller centers. Now, why is CMS removing those 4 measures, and how does it benefit ASCs?
Well, these removals are a welcome relief for us, John, because these measures don't reflect ASC quality. They were more about administrative compliance. The COVID-19 vaccination measure is outdated and really should have been dropped last year. COVID-19 is no longer a public health emergency, and ASCs don't require staff vaccinations anymore. Collecting that data was a significant burden, diverting nurses from patient care to track vaccine records that had no bearing on surgical outcomes. ASCA emphasized this in their July 2025 statement, noting the COVID-19 measure is obsolete, diverting resources from meaningful quality initiatives that enhance patient care.
Yeah, and I absolutely agree. The measure felt like a holdover from 2020. What about the other 3 measures?
The facility commitment to health equity and the 2 social drivers of health measures, screening and screen positive rate, are even less relevant to ASC operations. The equity measure required ASCs to implement policies like diversity training or equity-focused governance. While it was well-intentioned, ASCs are focused surgical facilities with limited resources. Most can't afford to restructure their operations for broad social objectives. The social drivers of health measures were particularly burdensome, requiring ASCs to screen patients for issues like food insecurity or housing instability during pre-op assessments. ASCs aren't equipped to address these social challenges or provide follow-up, making the data collection pointless. ASCA summed it up well, saying these measures impose administrative burdens unrelated to surgical quality, undermining ASC's ability to prioritize patient safety and care delivery.
You're absolutely right. I think we all agree that it doesn't improve patient care either, and it isn't something that we can impact as much as, say, a primary care physician doing a physical or a hospital can do with a patient that shows up in the emergency room. Though they don't necessarily have the time to deal with this either. But I mean,
they have the resources to do something about it if they discover a problem.
And I think it's important for us to note that we're not saying that these drivers that health equity isn't important. I think we all agree on that. It's just that the ASCs are just not the right environment for asking those questions. And I think we mentioned this when we talked about this last year, that when CMS created this measure in July of 2024, they kind of copied the measure from the hospital and pasted it into the surgery center regulations without making any modifications to it.
Yeah, this is really a huge win for ASCs, John. These measures would consume valuable resources, staff time, compliance software, training costs with no tangible impact on surgical quality. Removing these measures allows ASCs to redirect resources to critical areas like infection prevention, patient satisfaction, or staff retention. With nurse shortages, and some centers are down 10 to 15%, and supply costs rising 5 to 7% annually, this relief is critical. It also shows CMS is responding to advocacy from ASCA and the American Hospital Association, who've been pushing to eliminate unnecessary red tape. ASCA noted that these measures were a misfit for ASC's focused mission, and their removal helps centers concentrate on their core strength, which is delivering safe, efficient surgery.
And that's a significant step forward. So ASCs excel at focused, high-quality care, not administrative tasks that are unrelated to surgery. Now, that new proposed measure seems more aligned with our mission, more aligned with really quality care. What's the details about it?
The Information Transfer Pro PM is a strong addition. It measures how effectively patients understand their discharge instructions like pain management, wound care, or when to call a physician. It's voluntary starting in 2027, which gives ASCs time to prepare, and becomes mandatory in 2029 and will impact payments in 2031. It uses a hospital quality reporting system, which is familiar to many ASCs, so it's not too far outside of what many have already done. This measure is a true quality indicator because ASCs directly control patient communication. Clear instructions reduce complications and hospital readmissions, which really aligns with the ASC's goals. Unlike those social drivers of health measures that had us chasing unrelated goals, this one is practical and patient-focused.
Yeah, that's the kind of measure we need. And I really like to see them getting back to measures that we can all agree on are quality focused. Maybe not everybody will agree with that one, but it's certainly one of those measures that we often look at when we're doing patient satisfaction surveys, for example. And I don't think it's going to be a heavy lift to try to be able to gather the information for this.
Yeah, and it will be something that we can change if we notice there's a problem with it. We directly affect this.
That's a very good point, is that all of these quality, I'd like to see quality measures that we can actually have an impact. We probably, we wouldn't be able to have any impact on any of those social drivers there.
And I also want to say CMS is exploring new ideas through a request for information on well-being and nutrition measures. Think emotional health, social connections, or promoting healthy lifestyles. It's early, but it could signal a shift toward broader patient outcomes. ASCs should engage in the comment period to ensure these measures align with our outpatient surgery focus. ASCA is leading the way, providing templates and guidance to help members submit comments that resonate with CMS. They stress that new measures must be tailored to ASC's unique role, not borrowed from hospital frameworks.
Yeah, and I'm not quite sure where this is going yet, but I think it is encouraging that they're asking for feedback from ASCs right now. Again, promoting healthy lifestyles seems a little bit more like something that the physicians can do in their offices and hospitals can do. But I think, maybe having surgery centers have pamphlets or information available if a patient does ask for that type of information, I think that would be a good way to kind of implement this. Well, I hope this has been beneficial to everybody. There's a lot of information to cover in a short period of time. We're thinking about whether there's some other additional information, and we'd love to have some feedback if you'd like us to get more. But definitely look at our show notes, which will have a lot of information available right from the actual CMS submittal. So let's stay tuned for part 3, where we'll explore upcoming events in the ASC industry.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
The Florida Society of Ambulatory Surgery Centers annual conference and trade show is this week, July 23rd through the 25th, at the Hilton Orlando.
The Illinois ASC Association's annual meeting is August 21st and 22nd at the Crowne Plaza, Chicago O'Hare Hotel and Conference Center in Rosemont, Illinois.
And Sue, you and I will both be there. Actually,
we'll be fresh off of a cruise.
Fresh off a cruise. We're coming right from Vancouver to that. So
yeah, but that'll be fun.
So we'll have it. I don't know. It's an Alaskan cruise, so I guess we won't have a tan.
No,
but we will be rested. We hope. Yeah. So we're looking forward. Illinois conference is always great, and I'm looking forward to do an administrator boot camp there.
Yep.
CASA's annual conference is going to be September 3rd through the 5th at the Sheraton San Diego Resort in San Diego, California. I'll be there doing a session for a CAST review course, and I'm very much looking forward to doing a podcast from there also. We haven't done that in a couple years.
The Atlantic States ASC Conference and Trade Show is October 2nd and 3rd at the Embassy Suites by Hilton Raleigh-Durham Research Triangle in Cary, North Carolina.
The New York State Association of Ambulatory Surgery Centers Conference will be held October 6th through the 8th at the Desmond in Albany, New York. I'll be speaking during the conference, and we will be doing a special episode there. And Ambulatory Healthcare Strategies is sponsoring the pre-conference, which is on the 6th.
And the Oregon ASC Association's annual conference will be October 9th and 10th, 2025. John will be speaking at the conference, and we will do a special episode from there.
And the Michigan Ambulatory Surgery Association's Education Day is October 23rd through the 24th at the Boyne Mountain Resort in Boyne Falls, Michigan, and I'll be speaking there also. The OR Manager Conference is October 28th through the 30th at the Anaheim Convention Center in Anaheim, California. I'll actually be speaking at the pre-conference on the 27th on the CASC review course. You'll note that we're doing 2 CASC review courses this year, one for the California Association and the other one here for the OR Manager Conference. And I did this same conference last year. Hopefully we'll have more attendees this year as it continues to grow.
And the Joint Commission Ambulatory Care Conference is November 5th and 6th at the Crowne Plaza, Chicago O'Hare in Rosemont, Illinois.
The Washington Ambulatory Surgery Center Association's 2025 Annual Education Conference and Trade Show is November 6th and 7th at the Tulalip Resort and Spa in Tulalip, Washington. I'll be speaking at the conference, and I'll also be doing another special episode. I think this is our 3rd year in a row doing a special episode from Washington State.
The Colorado ASC Association's conference will be held November 13th and 14th at the Denver Marriott West in Golden, Colorado. John will be speaking at the conference, and we'll be doing a special episode from there.
And don't forget, on-demand versions of the ASC Director of Nursing, the ASC Administrators, and our Business Office Managers boot camps are available on our sister website at asc-central.com. And I do want to remind everyone to become a patron member of the podcast. As we're finishing up here, we're about to go into the weekly drop-in session, which during the summertime either occurs on Mondays or Fridays generally. And it's a great opportunity for you to get together with other patron members, boot camp members, and the staff of the ASC Podcast with John Goehle. And we usually have between 2 and 4 surveyors on that. So it's a great opportunity for you to ask questions about upcoming surveys or survey experiences or any questions about the ASC industry in general. So the Patron Program is a comprehensive membership platform, and it's your go-to resource for all aspects of ASC regulatory and accreditation, compliance, operations, and financial management. It really is designed for the busy schedules of administrators, nurse managers, and business office managers. By becoming a member, you gain access to our regular Zoom sessions, as we just talked about, and then you also unlock a wide range of additional resources, such as access to some of our virtual conferences, and you'll also find valuable tools like sample policies, procedures, forms, and our highly regarded fire and disaster drill kits. Your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit asc-central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community, and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com.
A special thank you goes out to our incredible team, the sound editor, Susan Cronkite, executive producer, John Goehle, and our committed research team, Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Calritis, Jim Masters, Amy Cronkite, Lori Rodericks, Kathy Foti, Donna Macchio, Christina Norman, and Katie Pearson. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah, and the ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll hope to see you on our next episode.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.